Hi, my name is Dr. Don Murphy. I'm a geriatrician with Rocky Mountain Senior Care and the founder of the MESA initiative.
And I'm Dr. Elane Shirar, the owner and founder of Rocky Mountain Senior Care.
MESA stands for Medicare Expert Senior Access. This was funded by the Colorado Health Foundation and other organizations in the past. Now, because of Dr. Shirar's good graces, we get to carry this on. Our goal here is to help teach anyone who's interested in taking care of seniors how to do this, how to make sure that you get paid fairly for the good work you do. And we really need you to know about coding, documentation, billing, all those kind of things that's necessary for a good, viable geriatric practice. Okay, we have several assumptions and our underlying philosophy. Number one, we believe that seniors, as well as other folks with chronic illnesses, deserve good care, and that we have the manpower to do that for the folks in our country. Number two, we know that there is a perception out there that the current reimbursements are inadequate. This is a tough population, requires a lot of work, both face-to-face visits as well as behind the scenes. But we believe that the system does work. There is adequate reimbursement to allow us to do a good job. In essence, we know that the Medicare reimbursement system is fair. Now, we don't know where we're going. We don't know what healthcare reform might look like. But what we're saying is that we do have a system that works. Let's use it. And wherever we're heading from here, we know we're going to be using the system for a while to come. Okay, we have to know the rules, right?
Right, absolutely.
We have to play by the rules, right?
Right.
Okay.
And we have to be good at the rules.
And we have to be good at the rules. That part we know. All right. So we're going to introduce you to Medicare coding and documentation. Inappropriate coding can include overcoding, in which case there's lost time and money from audits, and the potential loss of revenue, fines, or even license. So all of us want to avoid that. The cost of undercoding is significant too. If you undercode by one level, whether you're in the office or in a nursing home or whatever, you are leaving 20 to 30% of the revenues or more on the table. And that, most primary care practices cannot afford that. Is that not correct?
Oh, absolutely. In fact, just very quickly, a couple of years ago in my clinic, I had two providers who saw the same number of patients in a month, exactly the same number, and I looked at what they billed out. One billed out double what the other one billed out, and it was all based on coding.
Exactly.
So it'll make or break you.
Yep, it does.
Absolutely.
So all clinicians who do this need to know the balance. You do not want to overcode, you do not want to undercode. In the references, we have tables that give you the various levels, et cetera, et cetera. But I think we can argue that no matter what setting we're looking at, so it could be office, it could be nursing home, it could be assisted living, it could be a home visit, that when you look at the various levels of coding that Medicare pays us for the work we do that meet those levels, it's fair. Mm-hmm. You just have to know those different levels and how to appropriately document and code for those.
Right, absolutely.
The critical billing success factors are these. Number one, you have to bill accurately. So all providers should know how to use the ICD and CPT codes. That doesn't mean you can't rely on the tools that, like you've given us with our electronic record and all this kind of stuff. But you have to know the basics. Would you agree with that?
Absolutely.
Okay. You have to bill appropriately. Any encounter requires a justification of the medical necessity. It doesn't matter if it's a 10-minute visit or an hour and 15 minutes. Whatever it is, we have to justify the medical necessity of it. You have to know how to document that. You do have to bill courageously. In other words, you have to bill fairly for the services you provide, by the rules, and in my opinion, easy for me to say since you own the practice, you have to be ready for audits.
Right.
And I think we could argue, embrace the audits. None of us are out there looking for them, but you have to know that you're doing it all the right way, and if you get audited, great, not a problem. Let's talk about the two broad paths for billing. One is E&M, evaluation and management, and the second is time-based. And all clinicians need to know how to use both of these, when to use them, when to go from one to the other, et cetera. And obviously all the rules to follow for each one of these. So let's start with the E&M coding. Elane, tell me how to do my E&M coding.
Well, E&M coding is based on basically what you do in the visit. So it's based on basically 3 things in your visit: history, physical exam, and assessment and plan or decision making. And of course, and in the MESA information, it'll talk about an established patient. You only have to have 2 of those 3, but with a new patient, you do have to qualify in all 3 of those categories. But based on the category, it's the complexity and the depth of the history, the depth of your physical exam, and your assessment and plan that you actually separately code to bring together a final code for your visit.
Exactly. And let me just follow up on one point you made, that for a follow-up patient, we only have to meet criteria in 2 of the 3.
That's right.
And so this is something that you and I know we have to decondition, we have to reteach all kinds of providers.
That's right.
Let go of stuff that really does not add value to the visit.
Absolutely. I call it documentation guilt. Actually.
There you go, documentation
We've all
guilt.
been trying to do the complete H&P, for the most minor of thing, and it's not necessarily necessary, and it just takes time. We'd rather spend time with patients and taking care of patients and communicating, but yeah.
Okay.
So I think it's important to say there can be a visit, a very quality visit with a patient, depending on the circumstances, and the documentation may not even include a physical exam with an established patient. And we're fine with that as long as that's what the provider needed to do to make their decisions.
I hope that's the case, because that's at least 50% of my visits. Though I do have to show that I saw the patient, all right?
Right.
And I have to make the judgment, do I need to do the exam? Do I need to listen to their heart? Do I need to check this and this? And we're doing that all the time.
Right.
But I don't necessarily need to do that if it's not required.
Right.
And I meet criteria in the history and in the assessment plan, medical decision making. Okay, so let's talk more about, and the other thing is that for a new patient, no, we do have to do all 3 things. Yeah. Okay, so let's talk more about the history. Tell me what I need to do.
So the history should include, of course, for every patient, a chief complaint. And that's where it's a concise statement where you're going to be showing why you're seeing that patient. I mean, just a statement of necessity, why you're there, oftentimes in the patient's own words. And then, of course, the history of present illness would include a documentation of what you talked about, what the illnesses are you're addressing, kind of, I guess, maybe your table of contents for your whole visit, 1, 2, 3.
Yeah, well put. Okay, and often in terms of the HPI, it is a summary of the chronic problems. We might throw in a new problem. It could be a combination, whatever. And then there are some times when, no, we're just dealing with a new serious problem. Okay, but we just spell out what that is. Okay. Now, review of systems. I'm going to argue on this one. So in the history, you're right. Chief complaint, HPI, review of systems, and past history. Right. We'll get to that in a second. But I would argue in the review of systems, we ought to be doing the basic minimum. We do not need to go into all this other stuff.
Right.
Because we're really going into a lot of that in terms of assessment of symptoms as we're dealing with the problems anyway.
Right. A lot of times review of systems ends up being up in the HPI anyway, because that's where we're addressing the issue. And you're right, I so appreciate you bringing that up, because we don't need to be spending extra time typing things that aren't necessary for our decision making to document that, or our teammates who are seeing the patient later. They don't need to be reading that information necessarily. Right.
So I just want to offer the 3 ways I use the review of systems. Because again, if we're billing based on E&M, and let's say it's we're in a nursing home, it's a 99309, or in the clinic it's 214, whatever, we have to have anywhere from 2 to 9 review of systems. So I know that I have to have a minimum of 2. That's the formula. And so what I might do sometimes is either one, ask about those symptoms that are common in the geriatric population that might not have been covered by our team. I can look for side effects of medications in that. I might even pull a problem under the review of systems. So if someone, for example, if I'm dealing with Alzheimer's, hypertension, osteoarthritis, but yet I also want to deal with, do they really need the proton pump inhibitor for their GERD? I might go down and do a more comprehensive GI review of systems. So I mean, there are a number of ways that we can appropriately use this without doing all this documentation guilt stuff, right?
Right, exactly.
All right. Now the past history, past family and social history. I would argue that in darn near every geriatric visit we do, we ought to be reviewing the meds. Is that fair enough?
Oh, absolutely.
Not every visit. I mean, we're going to do visits in nursing homes where it's one problem and boom, we take care of it. We don't necessarily have to review all the meds, but for the most part, that's what it involves.
Yeah.
You with me on that one?
Absolutely.
Okay.
I agree.
Now, I'd also like to argue that if Medicare gives us credit for the past medical history, if we just do a medication review, that maybe we don't have to be worrying about the family history of a 90-year-old who, as an example. Is that fair?
Absolutely.
Okay.
Thank you.
All right. So the bottom line is that if you do a medication review, a good one, that's past medical history. We get credit for that.
Yep.
Okay.
Absolutely.
All right. Let me back up for a second on the review of systems, just to point out that if we cannot do a review of systems, whether it's only 2 systems or 10 or whatever, because of either dementia or language barrier or some other reason, and we indicate that, we still get credit for the review of systems.
Right.
Okay?
Yep. Absolutely.
All right. Oh, and one other thing. Let's go back even to the history. I mean, before we leave the history, it's important for everyone to know if you are reviewing, let's say you're in a skilled facility, someone comes from a hospital, and you review all the hospital records and everything, you don't have to put in your note, you don't have to spew out, just reiterate everything that's already been said.
Right.
What you do have to do is point to the pertinent information, you've reviewed it, how it ties in. And that's a much more condensed way of doing things than just...
Right, absolutely. Just refer back to it and
Right.
not utilize our providers to be clerks and,
Yeah.
and secretaries.
Exactly. Okay. All right, so that's a few history tips. Again, we mentioned you get credit as long as the whatever element in the past history is referred to and is relevant. This is key in terms of your review of systems or other past history. I mean, how can your staff, and this is key for all practices that are doing team-based care, I mean, they can do it, right?
Right, absolutely.
Yeah.
Yeah.
It doesn't have to be the clinicians that record.
Recorded.
And by the way, in your practice, I mean, you have these scribes just doing all kinds of stuff that's incredibly helpful.
Right.
And we have to review it, refer to it, but it
But
does
we
not
don't have to be the ones to type it.
You got it.
That's right.
Okay. All right, now let's go to the exam. What do you think?
So again, the exam should be justified by what you're addressing in that visit. If there's no need to do a full neuro exam on every patient, so you put in just what's pertinent, the necessary items that you did. And like we talked about, sometimes maybe we don't even put in an exam except to document that we did see the patient face to face.
Exactly, and I had mentioned, those are a lot of my visits, but I will also say that even though when I'm doing a follow-up visit and I focus on the history and the medical decision-making, not so much the exam, that there are those patients where it's very appropriate to rely on the history and the exam. That's where so in geriatrics it might be weight loss, recurring falls, delirium or change in mental status, progressive fatigue. Those things justify a full history, full review of systems, full exam, or they can.
Right.
And in those cases, you can easily justify a high medical decision making. I mean, you can justify, let's say in a nursing home, a 993-110. It takes you that long anyway. You're doing the right thing. Whereas in a lot of other stuff, again, the exam just isn't that important. It is, I think, important for all clinicians to know that in the art of medicine, we have to deal with patients' families who expect us to do that. And so we, whether we do it out of ritual or whether we explain to them, I've done this a lot over my career, is explain that the old head to toe, once a year cover everything. No, that's not how geriatrics works. It's more of a rolling history and exam, and you can cover everything over a period of time, but you don't have to do everything at one time.
And it's also, I think, good to point out that sometimes, even though you may not need it, to put the stethoscope on the patient makes everyone feel better.
Exactly.
So sometimes that happens.
Okay. Now, medical decision making or assessment and plan. Here, I would argue that a bread and butter for a geriatric practice is that level that's one less than the highest level, okay? That we are dealing with folks with just a lot of problems, a lot of medicines for the most part, and for us to do a good job of follow-up, we have to be looking at several things. And what that translates into is a fair number of, if you're in the clinic, it's a 214. If you're in the nursing home, it's a 309, assisted living 336, that kind of thing. Doesn't mean all the visits are like that, they're not. But we clinicians really have to know the basics of that, but also the other levels. Is that?
Absolutely,
Okay.
absolutely. But yeah, our
Okay.
patients are pretty complex, so a lot of them will fall in that range. But again, just like we're making decisions and doing decision making about the care of the patient, we're also doing that same decision making about what we document, what we choose to document, and what we choose to code.
Exactly. Let me just digress for a second and talk about the formula of E&M. And a reason that we teach about the formula is not because medicine is formulaic. It's not. It's because when clinicians know this formula and it just becomes second nature to them, it really frees them up to focus on the patient. Mm-hmm. It makes medicine more fun. We're more sensitive. We listen better and all that. But we have to have this mechanical stuff just boom, boom, boom. All right? So the simple formula is, and let's, what side should we talk about? Clinic, nursing home, or ALF?
Oh, maybe clinic.
Clinic, okay. So in a clinic, in geriatrics, if you're looking at a 99213, there you're talking basically 2 problems and 1 review of systems. And you do have to do a past medical history, that's your medication review. Mm-hmm. That's the formula. And by the way, when we get to time-based, we're going to find out that the time it takes us to do a good E&M is roughly the same time as Medicare says on time-based billing. Just how it works out. So a 214, again, bread and butter, if you're doing a good geriatric job in the clinic and you're allowed enough time to do all this stuff, that formula is basically 3 problems and 2 review systems. You can do 2 to 9, but you have to ask yourself, is all this other stuff necessary? Right. And then at the highest level, 215, I think it's fair to say it's hard to reach that level of complexity based on the guidelines Medicare has given us. And in my biased opinion, it's because Medicare designed these more for acute medicine than what we do.
Right, sure.
But we still have to live by the rules.
Right.
We do, even though we could argue it's hard to get a 215 based on medical complexity, that's the hard part. Mm-hmm. In terms of history and physical, it's easy for us to, we take care of that kind of a population. But medical complexity is tough. But I would argue that clinicians do need to know how to do that if they're going to do the transitions of care management. We'll cover that in a little bit. Okay, so you got to know the formula, and the reason you have to know the formula is so that you can have be more effective as clinicians. And then we have the tables that they can look at, and again, people should know the codes.
Right,
Yeah.
absolutely, and the time. That's
Yes,
appropriate
and
for
the
those
time,
codes.
exactly. Let's cover a few documentation tips, all right? So, is it fair to say that we ought not just say stable for a lot of stuff, even though it is stable?
Yeah, absolutely. Yeah, I mean, if you want to count that as decision making, you can't use stable.
Yeah.
So.
I mean, there's thought that goes into this,
Right.
and we ought to explain a little bit
It's
more.
not a rubber
why.
stamp.
Right, okay. And second, we should be more specific rather than just saying continue present treatment, which I do, fair enough, but I shouldn't just rely on that.
Right.
I should say, no, we will continue this medicine, we might look at a reduced dose, whatever, but be specific.
Exactly, and we've got peers who'll be following behind us. They need to know
Yeah.
what was continued treatment.
Right.
Yeah, current treatment.
And that we should summarize the discussions, whether it's with the patient, family, staff member, or whatever. To me, that's where our assessment plans should really shine.
Right.
You know, we do have these discussions, and okay, summarize them. We don't have to go in excruciating detail, but all right. Now, let's go to time-based coding, all right? This is when we can say that greater than 50% of the visit is spent on counseling and coordinating care. And quite honestly, in a geriatric practice, when we're dealing with all these different problems, not just medical problems, but psychosocial and everything else, we do, on a number of visits, spend quite a bit of time. It kind of gets wrapped up on how do we tie this all together. And that when we are spending that time, we ought to bill appropriately.
Absolutely.
Okay. I think it's great patient care. I can tell you, like today, for example, because of necessity, I had to make visits very brief. Whereas yesterday I had the time, and I spent an hour and at least an hour and a half with the patient, her daughter, the staff, doing the right thing.
Mm-hmm.
And yeah, so it's good that we can do that. Thank you for allowing me the time to do that, by the way.
Well,
But I have to know how to bill for that.
right, absolutely.
Okay. It's fair compensation. I would argue it's not as high. The compensation is not as high. For example, if I see 3 patients in an hour, and I'm billing based on E&M, you're going to get more money if I do that than if I see 2 patients in that hour and I bill based on time.
Right.
But still, it's fair compensation.
Right.
If I know how to capture my time, whether I'm billing based on time or not, it's fair compensation.
Absolutely. It'll average out.
Okay. And then another point here is that the E&M detail is not necessary if we're doing time-based billing, but I would argue our notes really ought to look the same, pretty much the same.
Yeah,
Okay?
absolutely.
And a key difference, I would argue, for if you're doing a time-based billing is you've got to make sure that in the assessment and plan, in your medical decision-making, you explain that you took time dealing with this.
Right.
So we can't just punchline that, okay, we'll do this, we'll do that, stop this, stop that.
Right.
We ought to be saying, let's say we're talking about Alzheimer's. No, had a long discussion with patient family, about the expected course, appropriate workup, and here are some treatment options. I don't have to go all the detail, but I need to say, no, we really did spend some time here.
Right. You got to document that you spent it and how you spent the time,
Right.
so that anyone who reads that note understands that that time was justified with that patient and family.
Exactly. Okay. Now, it's important to know the difference on time-based billing between location. So, in an outpatient setting, which includes home visits, assisted living visits, and clinic visits, it has to be face-to-face.
Right.
It has to be face-to-face, okay? So I can't spend a half an hour with you and then talking with the nurses or the QMAPs or whoever for another half hour and count all that time.
Right.
It has to be face-to-face. Whereas in a nursing facility, or even in a hospital, but in an institution, it's what we call floor-based, floor time. So if you're a nursing home patient and I spend 5 minutes with you, but then I spend another 30 minutes with the nurses, with your daughter, your son, with whoever, talking to the specialist, whatever, all that is floor time. I can use that time.
Mm-hmm.
Okay, and that's a critical difference that all clinicians need to know. When we are billing based on time, we should try and be as accurate as we can about the time. It's not really sufficient just to say 40 minutes. At the bottom of the note or somewhere, if you're billing based on time, you have to put the time, and you have to put greater than 50% counseling and or coordinating care. Sometimes we might just summarize the total time, but I would argue, let's say we're in a nursing home and I start seeing this patient and working on that, I get pulled away to see someone else or whatever. I go back and complete this patient, or then have a talk with the doctor, whatever. I can say total time 45 minutes scattered over 2 hours or whatever. I'm indicating that I was kind of pulled here and there. Whereas if I see a patient in a nursing home and I start at 8 o'clock and I go till 8:40, I would put from 8 to 8:40, greater than 50%. So we try and be accurate on the actual time spent. I think that your best clinicians, and when I say best clinicians, the ones who know how to take care of whatever needs might come up that day. It doesn't matter if it's in ALF, in your clinic, or in the nursing homes. Those are the ones that know, oh, wait a second, I only have so much time in a day. You're concerned about their quality of life, right?
Sure.
Okay.
Absolutely.
And they have to think kind of with the triage mentality. No, this I can take care of in 5 minutes. This is going to take 30. This, oops, I got this unexpected H&P that's very whatever, right?
Right.
And therefore, your clinicians need to know which path to go.
Right.
Yeah, and they have to know how to use both. All right. So, what I have found is that For stuff that's kind of what I think is going to be routine, this might be a follow-up visit, or it might be an H&P, okay? But I find like, oh, wait a minute, if I'm really doing a good job and I have the time to do this today, oh, this is taking a lot longer than I expected. That's okay, but I have to know how to bill based on time.
Right.
All right. And conversely, I will have visits where I'm thinking, this is going to take longer than I thought, but then I realize, no, wait a minute, my colleagues have taken care of this, or, I mean, there's all kinds of joint arrangements we have out there. Oh, this is taken care of, but regulations require that I see this patient. No, I can do this very quickly, and I don't have to bill based on time. I can just, bill the appropriate E&M. And I just find that there are so many cases where I think I'm going down this path. Oops, I got to switch and go over there.
Right.
My notes are going to look the same. I know that if I go on the time-based, I know what the time thresholds are. I know that they have to make them. I have to make them. And I have to indicate that greater than 50%. Fair enough?
Fair enough.
Okay,
Absolutely.
I'm just making sure I'm following all your rules, all right?
I think you're doing beautifully.
Thank you. Okay. Comment, in the past, we preached a lot about prolonged care services, but you've got some updated stuff on that, so
I do.
help us out here.
So basically we're finding there are some codes for prolonged care services, for example, the 99356 and 99357. Many insurances, a lot of them are not reimbursing for that. So a provider may put in a certain billing code and then add the prolonged care services code. It's a lot of times not being reimbursed.
Okay.
So.
Now, I could say doggone it, those insurance companies. How are they inhibiting us from giving good care? And you should say, well, Dawn, it's okay. Let's make this work, right?
Right, that's what we have to do,
That's
right?
what we have to do.
We love taking care of patients, so
Bingo.
we'll make it work. That's
there
right.
you go. Okay, but that is a key point.
Yeah.
If we're not getting paid for this, you then have to massage how the practice works.
Right, yeah.
Okay. So we do have within the slides and everything, the references, all the details about that. And I would also emphasize when it is needed. And when we're really stepping up, and let's say, for example, I'm in a nursing home, okay, and I spend, 70 minutes doing this, and I know that to add the prolonged code, the 356, I have to, if I'm going to use a prolonged code, I have to spend 30 of that minutes face-to-face with the patient. That's a little quirk there, but that's it. Mm-hmm. And my note, I have a good, what I would call 309, or better yet, let's say I have a 310 note. 99310, I follow all the E&M stuff for that 310, but I've had that additional time, and I then bill a 99310 and a 99356, because I can do that if 70 minutes is above that 65-minute threshold.
Right.
I would argue that doggone it, step up, and we ought not shy away unless you guide us to, because we're not getting paid for it. And then if we get audited by whoever, who cares? We did it the right way, right?
Absolutely. Absolutely. The other thing that maybe is fair to point out for the time-based billing as well is that, it can be so tempting just to sit with the patient and reminisce about things or chat about things, but we can't roll that into the time. And
exactly.
So, we have to be on point, on task, on target, and that's the only time that we can count.
Okay. Yes, but if let's say we have a patient and it was just after the Super Bowl and doggone it, they're a Patriots fan and they want to tell you how excited they are. Mm-hmm. And they want to trust you that you're a good caring clinician and human being and you can have a little banter about that. And it takes 1 or 2 minutes. That's okay, isn't it?
It's absolutely okay. You just can't count that in your time.
Okay, fair enough.
And we hope you do. We hope, because that's part of the doctor-patient or provider-patient relationship, but can't count that in the time.
All right.
So.
We do have, as part of the resources, these tables that put out by CMS that gives the typical time for any point of care, any point of service, and any level. And again, I would emphasize these estimated times really reflect the time it takes for us to do an E&M. It really does.
They're pretty close,
They
aren't they?
They really are close. I would also argue, and I've been doing this for years, I will forget these times. If I haven't been in a certain setting, ooh, what is that? So I hope that all of you would get these tables and live with them. You really need to be able to know what the thresholds are. Okay. Elane, let's now kind of go to some of the new stuff, relatively new stuff, that CMS tools they've given us to help take better care.
Sure.
Transition.
So yeah, one's transitional care management. And so it's basically something that is given to us as a possible code and something that we can get reimbursed for, basically for going above and beyond to make sure that a patient who goes from an inpatient services type environment, whether that be a hospital, long-term care, an LTAC, a skilled facility, basically Medicare A reimbursement, into the outpatient setting, which can be an assisted living, independent living, community, clinic, etc. And so it's to do several things, but one is to contact them when they're transitioning from that Med A facility or inpatient setting to the outpatient setting. Then there's certain within the website, there's all the criteria, but contacting them essentially within 2 business days of discharge. And then based on the complexity of the patient and how soon it is that we get out to see them, the maximum time frame is 14 days, but there is also a code for 7 days in a high complexity patient. It's to do both the work behind the scenes as well as the face-to-face work in making sure that transition is smooth and that all the information is gathered and the patient is tucked in nicely in their outpatient setting, essentially.
Right. Okay. Let me just comment on the medical decision making around the TCMs, and this gets back to the importance of knowing the highest level. Okay. So let's say someone is coming from the hospital, or maybe they're out in skilled care. You know, it's still a Med A stay, and they go back home, wherever that might be. But they've got a lot of stuff going on, and that the practice really ought to follow up within 7 days, if they can. Okay. Then here's where it's important to know the criteria for high complex medical decision making. So Medicare says you look at 3 things under medical decision making. Number 1 is the number of diagnoses. Well, that's easy. I mean, come on. We're always going to get 4 more in geriatrics. 2 is what they call risk. How seriously ill are they? Well, these folks coming out of the hospital and who have settled down, they're no longer at high risk. It's hard to make that case there, okay? But we can make it for 3. 3 is the amount of data we look at.
Right.
So as long as we've seen what the hospitalist has said, the cardiologist said, the x-rays, the tests, and boom, 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 that's easy to gather. 2, and Medicare's only looking for 2 of these 3 criteria. You have to meet it at that. So in those TCM visits, as long as you've reviewed all this information, which does take time. Oh, by the way, TCM is not billed based on time. It's strict E&M. But as long as you've looked at all that information, you have a number of diagnoses, that makes it there. Now I want to contrast that there to a clinic patient or an outpatient on high medical decision making. And this gets back to what we were talking about. It's hard to meet the highest level based on medical decision making in the type of practice we do. And it's this. Look at those 3 criteria again. So let's say I'm in the clinic or I'm doing a home visit or whatever. I can get the number of diagnoses. Again, our patients have all kinds of things. I'm getting the amount of data is a little tougher because, no, they haven't been sick up to that point. It's not like there's all this stuff that we need to look at. Right. And the third one, the risk, well, here's what I would suggest as a litmus test. If you have a patient, again, outpatient setting, and you're saying, do I need to send them into the emergency room or not? That's high risk.
Right.
That's high risk. And in that case, we've met 2 of the 3.
Yeah, that's a great litmus test for us to all remember.
Right, and so that's a whole different setting. The outpatient, getting sick, do we send them into the ER? No, that's high complexity. Or the transitional care. No, things have settled down, but boy, we're having to review a lot of stuff.
Right.
In both those cases, we make the criteria for high medical decision making. Okay. Let's talk about chronic care management. Now, in my opinion, this is a huge boon for primary care. And it's not because Medicare is paying us gobs of money to do this. They're not. But they're paying us something. Right. And that is so important. So in chronic care management, we basically have to follow several different requirements by CMS. And before I get into those, Elane, tell us, I mean, CMS has made this easier for us, right? Compared to last year or
In
this year?
2017.
So explain how that happened.
Well, we had to have actually a written authorization or consent by the power of attorney or the patient, if appropriate, in 2016. But 2017, we can do that verbally. So that's one, huge way that we can make this happen. So there's significant changes to it.
And that does matter a lot. Yeah. So what CMS is, and I like to teach patients about this. I mean, when I used to get their written consent, now I'm getting the verbal consent, I still teach them. And I say, in 2015, Medicare decided for all the practices, they knew that they had to pay practices a different way. Okay, it's all part of this reform or wherever we're moving. They know that there are very few clinicians that want to do this, can do this, etc. They got to pay a little differently. And they recognize that they have to pay for a lot of the work we do behind the scenes. So they came up with chronic care management at the beginning of 2015. They promoted this throughout our land. Okay, but very few people used it. Now we're saying, no, we all ought to get on board, because what Medicare is saying is if over a calendar month, your practice, so anyone from your practice, it could be me as a doc out there, it could be our NP or a PA, it could be our MA in triage, anyone. Mm-hmm. If anyone from your practice is doing some work to help Mrs. Smith, okay, and it could be emailing, it could be talking, it could be all kinds of stuff. We document that, and we show that over a calendar month it's greater than 20 minutes. We get to charge Medicare, right?
Absolutely.
For CCM. Mm-hmm. And what they pay, $40 or $41. Mm-hmm. We have to explain that to the patient and family. We have to say that there could be a copay, like any Medicare service. Right. They cover 80% of it. The other 20%, we're hoping that all the secondary insurances will cover it. They should. And we have to let the patient and family know what our plan of care is. Right. Those are the requirements.
And the patient has 2 or more chronic conditions.
Exactly. Right. Mm-hmm. And again, in our geriatric practice, that's darn near.
Yeah.
Well,
we need to be
at least 90%.
We need to be looking at the charts that don't have that.
Yes.
See what we're missing.
Now, can I suggest, and this is to anyone in primary care, that if you look at over the last year or two, or if we had this in place, there's a fair amount of money you've left on the table.
Oh, absolutely.
If we're not charging for this.
Oh, absolutely. I had a PA ask me today, because call is, we all get woken up and it's burdensome. And she said, are we getting paid, is our practice getting paid for call? Because it's quite a burden. And so I mentioned CCM, chronic care management. I said, at least they're recognizing all the work that we do behind the scenes. And so consider, that if we have these criteria met that you just described, we'll get paid for the calls for on-call.
That's right.
So yeah, it's a way to really, it's nice that they've offered to do this and have made it possible for us to meet this benchmark to do this with some of our patients.
And I've heard some other projections that it might not just sit at the 20-minute threshold. It might, go to 40 and I mean, they might pay more for all the other stuff, because I can tell you, I can't tell you how many patients that if I add up a calendar month, how much I'm talking to the daughter or whatever, there's a lot.
There is a lot behind the scenes.
The other key reason for doing this, I believe, is because it's a huge psychological boost to those in primary care who are doing a lot of care behind the scenes. To finally say, oh, Medicare actually recognizes the joy we get in this, the burden we have in this, but it's good work we want to do, we're going to keep doing, and they're going to pay us a little something for us.
Right.
That's key. Okay.
Absolutely.
So that's chronic care management. Advanced care planning. Now, I've argued for years we get paid for this by time-based billing, but I would now argue that the new codes that we have for this is even better.
Yeah.
And that, clinicians need to know how to do this. The first 30 minutes is one code, the second 30 minutes, if it goes that long, is another code. Within the first 30 minutes, what that means, and everyone agrees on this, it's got to be a minimum of half of that, 16 minutes or above. Well, any good advanced care planning discussion probably lasts that long. We ought to be billing for that. And tell me something about, it's not just one time, right?
Right, absolutely. Every time basically that we have that discussion with the patient, or there's a change in the plan. So yeah, absolutely.
Yeah. So really everyone needs to get on board with that.
Yeah.
Incident 2. Go.
Yeah, so, incident 2, our NPPs, our PAs and nurse practitioners are, we know, reimbursed at 85% of the Medicare allowable for the work that they do. But Medicare has made it so that some of our NPPs in certain circumstances can get paid at the 100% of reimbursement, basically what a physician is reimbursed. But we have to, of course, meet very strict criteria with that. First thing to know is that that only happens in a clinic. If in a nursing home or an assisted living community, we do not bill incident 2. The physician also needs to see the patient for new issues, so frequently see the patient so that we can document not only is the care being managed by the NPP, but also the physician. And the physician has to be on site at the clinic location when these codes are billed. So it's something to watch and manage very closely to make sure that we are meeting that criteria. But when we do, it's a nice reimbursement addition, that extra 15% for our NPPs and the hard work that they do.
And I think it's fair to say that any practice that's catering to a large senior population has to have good NPs and PAs.
Absolutely.
We're
Good point.
We're dinosaurs. Okay, can we agree on that?
Yes, unfortunately.
Good. All right. Preventive care. You do this in your family practice? Tell us
Yes,
about that.
absolutely. So, there's a couple of encounters and visits with a patient that we are able to do, which of course greatly improves overall care for our patients. One's the initial preventive physical exam. Once a patient has that birthday and they're able to go on Medicare, we have a 12-month window of either basically use it or lose it, where we can schedule with them to do basically a welcome to Medicare physical and full exam. Again, there's a guide on the MESA website with more information about that, but that's a one-time thing. Can't do that more than once, and it has to be within the first 12 months of switching on to Medicare.
Okay. How about the annual wellness visit?
So the annual wellness visits are great. Those can be done basically at any time. So that would hopefully that we are our colleagues out there watching this are doing the initial welcome to Medicare visit. So anytime thereafter, after that first 12 months, an annual wellness visit can be done. It can be done at any time as long as it hasn't been already performed by another provider in that 12-month period. And there are certain criteria that need to be met as far as documentation, and certain things have to be followed with respect to the patient, certain discussions, but that's on the MESA website. But those are great, and it's such a great way to connect with our patients and their families, to have that long, intensive visit once a year, which is nice.
And also, can't a lot of your staff collect the required information, allowing the clinician to have more time?
Absolutely,
Okay.
yes, the good point, yes.
Home care or
Yeah.
home care certs?
Yeah, so there are some G codes available for home care certifications. So again, we are, as a practice, our providers are certifying that patients require home health care, etc. And so there are some G codes on the website that practice can bill. Those are typically billed once a calendar month if certain criteria is met, but they're very helpful. And there's also a care plan oversight code that all of our clinician colleagues should check on the website.
Okay. And then finally, let's talk about home visits, because information we're getting just this week, I think illustrates how all practices have to be flexible and adjust to whatever Medicare is sending our way.
Right, absolutely, and I think that also brings up, we also need to, just like we've done in the last week, always to be double checking that what we think is right is actually, regulation. So there's always that circling back. But yeah, we're learning that there are some nuances to the new to the new regulations about doing home visits on patients, about necessity issues. They can't be visits of convenience. So I highly urge all of our colleagues to check the website if that information is on there and make sure that they're following that appropriately.
Okay. All right, and finally, audits.
The A word.
The A word. Now, I've argued for years embrace audits, don't be afraid of them. But boy, that's easy for me to say now that I don't have to worry
Yeah,
about that.
it makes the blood pressure go up, doesn't it?
So,
That's where
you as the owner, tell me what you feel about audits.
Well, that's where the rubber meets the road on,
Right.
what we think we know. But I would highly urge all of our colleagues to, be informed, double check on a regular basis the regulations, but not practice or code out of fear. I spoke at AMDA a couple of years ago, and someone raised their hand. She was an NP from another practice. And she said, our practice guideline is we will not bill the highest code because we're afraid we'll be audited. And I highly urge our colleagues not to do that, but to instead code fairly, be informed, learn as much as you can, double check yourselves, but bill fairly. I think that's what Medicare and the insurance companies intend. And that's where your practice is going to be financially viable as well. So.
Exactly. Okay. Can you bring us home by telling about some resources?
Yeah, so there's this great website that this man I know, Don Murphy, created called www.coloradomesa.org. Great things on there. Obviously, lots of printable documents. The grid that you mentioned with the number of minutes per visit is on there, in addition to webinars and all kinds of pearls and protocols for clinical faculty and clinical clinicians. So I highly urge everyone to check the website, download all of those documents, and review them. They're all very, very helpful. So.
I want to thank whatever audience is out there for helping us on the mission to take care of seniors and related populations. And Elane, I want to thank you for keeping this going.
Oh,
We
absolutely.
really
Thank you.
appreciate it.
Thank you.